So I have the opportunity to introduce Alexandria Rains, and we are so excited to be participating in both this statewide discussion around the way that we approach alcohol use in pregnancy and fetal alcohol spectrum disorders, and to bring her here today to talk to us more about her role at NFI and as a facets trainer. So, Alexandria or Allie Rains is a clinical case manager with NFI Vermont's community-based services program and also a certified neurobehavioral facilitator through the Facets Center for Neurodiversity. Her work focuses on supporting children and families navigating complex neurodevelopmental challenges, including fetal alcohol spectrum disorders, through a neurobehavioral framework. Hallie helps caregivers, schools, and providers better understand brain-based differences in behavior and helps build supportive environments that improve outcomes for individuals and families. And I want to thank you for being with us today, and I will turn it over.
Thank you. Thank you for introducing me, Michelle. Um, yes, and I'll also add that I'm a community provider in that AAP cohort with Michelle and many other providers, which is an honor as a non-physician. So, um, yeah, so today I'm going to be talking a little bit about the stigma that we were just discussing, as well as the impacts and what specifically care in Vermont can look like. So we can jump right into the next slide. So I'm going to talk about what fetal alcohol spectrum disorder is, understanding the spectrum of prenatal alcohol exposure and its impact on neurodevelopment, the diagnostic gap, which was already touched on beautifully, exploring why most individuals with FASD remain unidentified and misdiagnosed throughout their life, which will connect a little bit to the conversation we just had, as well as maternal supports, addressing stigma and creating compassionate systems that enable early identification and intervention, and the neurobehavioral framework and recommendations for approach utilizing case management and systems level change in the state of Vermont in particular. So next slide, please. Okay, so I also have a little like quote story-ish. But children who are misunderstood, imagine a child who's bright, funny, and curious, but every day they're told they are lazy, defiant, and not trying hard enough. Many of the individuals may have fetal alcohol spectrum disorder, which is becoming largely the most common developmental disability and is also still the least recognized neurodevelopmental disability. It's estimated that 1 to 5% of the US population is going to be diagnosed from a psychological lens, and most individuals remain undiagnosed throughout their life. It's present significantly in child welfare, education, justice systems, and is rarely identified. One of the key factors to this is beautifully, we are improving cohorts and ability to diagnose on a more broad spectrum, but historically speaking, as many of you well know, diagnosing fetal alcohol spectrum disorder has required certain facial features and detection of certain diagnostic specifications, which, as the data is now showing, really only shows up if you're utilizing or using alcohol in the first like 9 to 14 weeks of pregnancy. So you can use before and after, and those physical features won't show up. So many people are underdiagnosed or misdiagnosed. I also will be talking later when we talk about maternal mental health. What we're seeing in the state of Vermont is generations of neurodevelopmental differences that are undiagnosed and unsupported. So many times in the work that I do, I end up discovering that biological parents are also on either a neurodevelopmental spectrum or have fetal alcohol spectrum disorder themselves, and that has gone unsupported and has led to an increased predisposition for addiction. Okay, next slide, please. So prenatal alcohol exposure creates permanent brain-based differences, as we're well aware. So it includes a spectrum of disorders, including fetal alcohol spectrum disorder, fetal alcohol syndrome, partial fetal alcohol syndrome, alcohol-related neurodevelopmental disorder. I will tell you right off the bat, in the system of care in Vermont, none of these diagnoses are going to actually get a person help. So as we know, the root cause is prenatal alcohol exposure, which affects brain development, creating permanent structural differences. These are brain-based differences, not willful behavior or character flaws, as you all well know. But it's a critical reframe that's needed in our system of care and education in the state of Vermont in particular. Next slide, please. So when we look at the impact of fetal alcohol spectrum disorder, the brain-based difference, there's a lot of can't versus won't that we're seeing in the general population and the youth, but as well as in adults who are undiagnosed and often end up in the system themselves. So we see executive functioning challenges with planning, organizing tasks, controlling impulses that affect daily decision-making and goal-directed behavior. Something we talk about a lot with individuals on the fetal alcohol spectrum is a lack of ability to generalize. So a learned concept in one area will not follow them into another area. This applies to both incentives and consequences. So when we're using in our systems of care and in our educational systems, reward and punishment, it rarely works because we have a lack of future think as executive functioning challenge. This is, we might be able to think, okay, after work, I'm going to go to the grocery store, I'm going to pick up these 3 ingredients for dinner, and then I'm going to go home. That future think is much more hindered in the executive functioning of individuals with fetal alcohol spectrum disorder. So being able to predict that there's a consequence to this action that I've been told about there's a disconnect there. As well as adaptive functioning, so challenges with daily living skills and social navigation that affect independence, routines, and successful community participation. Sensory regulation systems are impacted with difficulty managing sensory input and emotional responses. This often results in overwhelm, avoidance, or atypical reactivity to stimuli. We hear parents and providers and educators saying they went from 0 to 60. We didn't see it coming. This is often a struggle with sensory integration as a result of brain-based differences in fetal alcohol spectrum disorder. Memory and learning, so difficulty retaining new information and recalling learned material, impacting academic performance and skill acquisition over time. Many kids, once they reach the state of an individualized education plan or alternative education, they end up being tested cognitively, and this leads to struggles with working memory and processing speed. So this does not mean that these individuals can't learn. It means that oftentimes the approach that we use is difficult. And in speaking to what I will get to when we talk about maternal mental health, when we're doing these screenings or having these conversations, sometimes the information that might be shared, if the individual you're speaking to is also on the spectrum, that information will not be retained or remembered appropriately. We see this in what is called blind spots in fetal alcohol spectrum brain processing. So this is, they might hear or read every third word. So if you take a message like, this is an exaggeration, but drinking alcohol in pregnancy will have negative impacts on your child. If the mother themselves also has neurodevelopmental differences, especially as related to opioid or alcohol exposure in their prenatal experience, they may only pick up on like alcohol in pregnancy and then they try to fill in the gaps. And this is what we call confabulation, which we see both with people who heavily drink and with individuals with fetal alcohol spectrum disorder, which is an altered sense of reality, which often leads to what looks like lying or the inability to fill in the gaps. So they're missing information. There's auditory processing that is impacted. And so they fill in the gaps with their brain. They create the answer. And so that it's important that we address by slowing down the way that we engage with people. I know that's really difficult in the medical world as well as the mental health realm where we are on a clock with our clients and patients. We call these individuals 10-second people in a 1-second world, which is we got to slow it down. We got to slow down what we're saying, how we're saying it. We have to narrow down what we're using for words. Alcohol in pregnancy is bad. Here's why. We don't need to judge, right? For kids, that also becomes more complex when it enters into education in the academic environment. if you're sitting in a 45-minute class and the teacher's reading to you and then moving on to a reading comprehension activity, you're going to fall behind. Not because you can't understand or can't learn how to read, but because it's just moving too quickly for your brain to process. So again, processing speed, slower understanding in response to information, which can lead to delayed reactions and increased time needed to complete tasks. This does, I want to emphasize, really also apply to adults in our population. And cause and effect reasoning, as I talked about, impaired ability to connect actions with consequences, making it harder to learn from experiences and adjust future behavior accordingly. This is exceptionally important both for the youth that we work with in Vermont, but also with the adults and caregivers that we're working with. This means that this is a repeat situation. That's why I love the women's group idea, ability to meet consistently and talk about supports and be open and honest, because your repeated messaging is going to be essential for it to be heard and felt. Next slide, please. Okay, so despite affecting 1 to 5% of the population, as we know, most individuals with fetal alcohol spectrum disorder never receive a diagnosis. This diagnostic gap creates decades of misunderstanding and inappropriate interventions, as I've mentioned. So as already discussed, barriers to diagnosis include maternal shame and stigma, lack of universal screening, limited trained diagnostic clinics, which we're hoping to change in the state of Vermont, provider unfamiliarity with FASD. This group, largely who's at this conference, is familiar and or aware. Many providers that I encounter in my day-to-day work are not aware of its existence, let alone its impact. And symptom overlap with other conditions. Many of our clients come to us with oppositional defiance disorder, ADHD, suspected autism spectrum disorder, but they don't quite knit the categories because there's a little bit of distinction between the two diagnoses. So often they're diagnosed with something else. The consequences, again, attachment disorders, it's probably not a surprise to any of the individuals in this space that many individuals on the fetal alcohol spectrum disorder end up in the system, the family support system, DCF. They end up in foster care, they end up in adoption situations. So it's also important that we're educating foster parents and adoptive parents on the impacts of fetal alcohol spectrum disorder, triage, and exposure in intrauterine examples, because it's highly prevalent in our foster community. Root causes remain unaddressed, secondary symptoms multiply. This is speaking to as we address things like ADHD or anxiety, we are still not addressing the underlying brain difference, and that can often lead to, quote, failure within the community, within the home, within education, because we're putting Band-Aids on the wound as opposed to addressing this brain needs a different approach. And that's what we'll talk about with the neurobehavioral approach. So we are seeing an escalating behavioral crisis in Vermont. I'm sure that's not a surprise to any of you. Our emergency rooms, first call is our crisis service in Chittenden County. I know there's HCRS in Southern Vermont. There's other services throughout the state, but crisis youth services and stabilization centers. We have hospital diversion program through NFI, Brattleboro Retreat, Jarrett House through the Howard Center, and these places have a lot of turnover with their staff, as well as a considerable wait list with youth and individuals. And that's just for children. There's also stabilization for adults. Next slide, please. Also, so something we're hoping to change in the state of Vermont, but is while we're talking about the children as a result of the fetal alcohol spectrum disorder, once there is exposure, as I mentioned, fetal alcohol spectrum disorder is not recognized or a billable mental health diagnosis currently, which means that clinicians such as myself cannot serve youth or adults or families primarily with a FASD diagnosis. It can't be billed, which leaves individuals without access to diagnosis-driven services. So they have to get subsequent, those Band-Aid diagnoses, they actually currently have to have those diagnoses, ADHD, PTSD, in order to receive the mental health services that would be supportive for them. So we treat their secondary symptoms. We focus on anxiety, depression, ADHD, rather than the underlying neurodevelopmental condition, which results in symptom-targeted care and often leads to continuing crisis. Without addressing the neurodevelopmental disability, interventions are mismatched to needs and often fail to produce sustained improvement. So we are in this cycle of services, behaviors worsen, repeated crises, and exhaustion on both the client, their family, and the system of care. It's also a financial and clinical misalignment that's perpetuated this diagnostic gap. I will say specifically for mental health services for families and youth in the state of Vermont, there is one service in the entire system within Chittenden County that is accessible through private insurance. The rest of us will only service Medicaid or supplemental Medicaid. So that means that case management for children and families that is through private insurance will actually receive less support than if they're on Medicaid or supplemental disability, which requires a lot of advocacy and understanding executive functioning wise of filling out those applications, accessing somebody that can support with that, right? So we have that financial barrier and insurance barrier as well in our system of care. Next slide, please. So I won't belabor this because we got into a beautiful conversation about this already. But as we know, that one of the biggest barriers to early identification of fetal alcohol spectrum disorder is maternal stigma in the screening process that we were talking about. So alcohol use during pregnancy does require compassionate understanding. Substance use disorder, as we know, is a medical condition that requires evidence-based treatment and support rather than punitive responses, especially during pregnancy. Preaching to the choir here, as I know. As mentioned, I think Dr. Xu brought this up quite a bit. Unresolved past trauma frequently contributes to substance use during pregnancy, and trauma-informed care is essential to addressing root causes. As I said, we live in a state, a country, but a state where there's significant generational trauma. Many of the youth in our system of care have biological parents who have undiagnosed PTSD, substance use exposure in their prenatal experience. And struggle with executive functioning skills. And as a result, they weren't able to meet the DCF requirements to regain access to their children, and they just kind of fall through the cracks. And then the children still have the effects of that unresolved trauma. And so we are trying in our community to serve and treat the children. But the parents and the generation that is raising them or birthing them is not receiving the trauma-informed care that we would like to be able to offer and provide. Lack of resources. So we know there's a housing crisis. Limited access to healthcare creates substantial barriers that prevent pregnant people from obtaining timely support and services. I know many people are unaware that they're pregnant. They're avoiding medical care. They are, of course, as we know, avoiding talking about this. Especially in the state of Vermont, we have a significant fear of DCF involvement and removal of child. We've had a couple of articles in the last few years where women's babies were taken from their custody pretty much in the delivery room. And this, I'm not saying that's common, but that knowledge resides within the heads of birthing people. Many people have limited awareness of how alcohol affects fetal development. Clear, non-judgmental education is needed to inform safer choices. I love the idea of being able to provide more just generalized normative education, as Katie mentioned. And I also want to add that when we have this executive functioning barrier, neurodevelopmental differences, a significant history of substance use, the brain is altered, and sometimes those information pamphlets are too much to absorb. So exploring multimedia is also very essential. Infographics are wonderful, videos, podcasts, audiobooks, things that people can listen to or absorb in a different way as opposed to just reading and conversation. Not that those aren't beneficial, they absolutely are, and some of our population won't be able to retain that information or understand it. I think we talked a little bit about language and terminology, and language, as we know from a cognitive psychology standpoint, is also incredibly impactful. and the words that we choose to use when we're interacting with people. It's not just the judgmental words, it's also the big words that we use. And I know that we try very hard to be understandable across demographics, and really using common language that is understandable. I think it's easier for us when we're within the professional sphere to kind of lose sight of what is a big word to other brains. Um, and I have had people ask questions about words that would surprise you. So just keeping that in mind in terms of your interactions with patients, both adults and children. And of course, fear of judgment, legal consequences, loss of custody, as I mentioned, many people conceal, and that prevents early identification and access to supports and intervention. Next slide, please. Okay, so we talked about this already. There are critical windows that many providers are failing to use, both because of stigma on the maternal or pregnant person's perspective on concealing information, but also on a fear I want to say that we know exists within the medical community of making assumption or asking these questions and offending people. So we do see minimal alcohol use screenings during pregnancy. I know for myself, it was that initial like tablet or piece of paper that you fill out about how many drinks you drink a day, a year, whatever it is. And if you answer that a certain way, it doesn't necessarily get brought up in your prenatal appointment, depending on where you are. Hospital delivery, prenatal exposure is rarely documented at birth. Postpartum wellness, we've already touched on this. There's a lot of focus on infant and not maternal history. Something that is becoming more prevalent in the psychology field is having screenings focus on mental health history and trauma background, as well as medical history. I know that there are some providers who are very good at doing that, but this is also a gate into having the conversation about mental health and as was talked about, like what is substance use disorder, what is trauma, what is self-medicating, because if you've lived in a cycle of generational trauma, you might not even know what trauma is at that point, right? So having those conversations can be really helpful. Of course, pediatric screenings, developmental checks don't often ask about prenatal exposure to alcohol. In early childhood services, there's often a misconnections between behavior and prenatal factors. We often, early intervention, when kids are referred to early intervention services through our family service programs, we focus on language delays. Did they have hearing struggles at birth, eyesight, and autism or ADHD. We rarely ask the screening questions of exposure to any substances in uterine. As we know, early identification could prevent decades of misunderstanding. Every missed screening is a potential life trajectory altered, not only in preventing alcohol use in pregnancy, but also in accepting that we did use in pregnancy. Here is what we do now. Here's how we support your child. Here's how we support you, both in ongoing treatment postpartum, as well as your child will be impacted, but that doesn't mean that they can't live a successful life. Here are the supports. So yeah, just really highlighting these missed opportunities with prevention focus, but as well as prioritizing screenings across these critical windows. Next slide, please. As we know, maternal support must replace shame. Compassionate systems enable disclosure. So we know this, but when mothers feel safe to disclose, children can be identified early, and support from mothers is support for children's futures. A large focus of mine in the case management clinical realm is parent education and parent support, because by the time they get to us at my program is an intensive wraparound program. So we are pre-residential treatment for children. We are the last step at keeping children who are really struggling with emotional and behavioral regulation. That support for caregivers is essential for the well-being of our youth. So of course, non-judgmental screening, routine, compassionate. I love the support group idea. I love the idea of normative conversations. non-judgmental conversations and prenatal alcohol screenings, accessible treatment, so substance use treatment during and after pregnancy, which we just talked about is lacking and is not based in some evidence to support what is supportive. And we do know that we're lacking in treatment for that in general in Vermont. Of course, trauma-informed care, addressing root causes with empathy and mental health support, so integrated behavioral health services, and postpartum follow-up, continued support for at-risk mothers. Again, let's say we successfully screen, we successfully prevent, we successfully treat, and then we drop off during postpartum support. That is also a pivotal time for parent and child, as we know. Next slide, please. Okay, so I'm going to talk a little bit about the neurobehavioral model now. Just my goal is to just reframe behavior as brain-based communication and not willful defiance. I urge you to consider your patients as adults as well as the children and newborns that we are trying to support. Next slide, please. Okay, so the neurobehavioral model focuses on behavior as communication of brain differences. Many models that have been used in the state of Vermont as well as throughout our country have focused on a humanistic but behavioral approach, which has led to let's try to reduce, eliminate, incentivize behavioral change as opposed to the underlying brain-based cause for these behaviors. So traditional model might see a child as oppositional and defiant, manipulative, deliberately non-compliant, lazy or unmotivated, resulting in punitive responses that escalate to problems. I will also highlight that this is how we handle adults who act this way in our system of care. So the neurobehavioral model has a paradigm shift, behavior as an expression of brain-based differences, so not character flaws, issues with executive functioning, memory and processing challenges, misreading as defiance. The facets framework understands the brain to understand the behavior. So the result is supportive responses to improve outcomes. So we try to shift from what's wrong with this child or why is this parent not listening to me to what's going on in their brain and how can I meet that need. Next slide, please. So case example, this is not a specific case, but when defiance is actually executive functioning impairment. So in a traditional interpretation, the problem might be a child that repeatedly breaks the same classroom rules despite multiple reminders and consequences. In the adult realm, this might look like you're trying to do that alcohol consultation. You're trying to have these conversations. They go, no, yeah, I'm fine. They walk away and you hear through the grapevine and through their care coordinator that they're not fine, they're struggling, right? Like this, you get frustrated, they're lying to me, they won't tell DCF the truth. I just want to help, right? Interpretation, the child knows the rules, but is choosing to break it, which leads to oppositional behavior, right? Like this parent is lazy, they're in denial, they don't want help. This leads to escalating consequences. For a child, it might look like loss of recess, detention, suspension. For an adult, it might mean less empathetic care. It might mean DCF involvement. It might mean court hearings and, housing struggles, that kind of thing. So the outcome in the child realm is behavior persists or worsens, relationships are damaged, and they end up bouncing through the system to higher levels of care, isolation, that kind of thing. In the adult world, it's got bigger consequences, jail time, loss of custody, loss of housing, loss of job, that kind of thing. So from a neurobehavioral interpretation, the reality is that a person who's repeatedly breaking the same rules, a child in the classroom that needs multiple reminders and isn't responding to consequences, an adult that you feel like you're having this conversation with, you need to show up to your visits, they're not showing up to their visits, right? The interpretation is the child may not retain the rule and cannot generalize across settings. So they struggle with impulse control due to executive functioning deficits. This parent has expressed that they want to do well for their child. They want to stop drinking. They want to attend the DCF visitation so that they can regain rights of their child. They've expressed that, but their behavior goes against it. That's an indication that it's an executive functioning issue and they don't know how to get from A to Z. So the response might be to alter our approach. For a child, it might be we use visual cues. We reduce the verbal load, right? We slow it down. We say fewer words. consistent repetition of message, and environmental supports. This also works for adults. So again, like I said, in your screenings or consultations, a little visual that's laminated that they can put on their refrigerator that reminds them of the important things to do. Take your prenatal vitamin, attend this appointment, no, don't drink. Right, like those kinds of things can be really helpful. Slowing down how you talk to the adults. And this is not to say like we're not trying to offend people by making them think that they're less intelligent. When I say slow down, I don't mean exaggerate. I just mean we have a tendency to rapid fire talk. And it can be easy for things to be missed. Consistent repetition is why those groups are so important. It's why those check-ins from a hospital social worker are so important, because it's a constant reminder. And then, of course, environmental supports, which is more on the psychosocial realm. And the outcome is behaviors improve when the approach matches the brain's needs. So changing our response can change the trajectory. This is a reframe that we're hoping to influence throughout the systems of care in our state and the country. Next slide, please. So the hope is to reduce the crisis cycles by addressing the root neurodevelopmental needs. So reframing behavior, as I just said, helping families understand that behavior is brain-based, not willful, both for themselves and for their children. Coordinating services, so bridging medical, educational, and mental health systems. This is where case management, such as programs like NFI, the Howard Center, often have case management programs that will help coordinate services, supports through education, supports through connecting with medical care coordinators or physicians, attending care conferences, that kind of grouping and support so that parents aren't overwhelmed by the number of resources and appointments and everything. School advocacy, securing appointments and accommodations, accessing 504s and IEP supports. Many parents are not educated on being able to make these requests for their children, and many schools are told to not bring it up unless it's brought up, right? Caregiver education, of course, teaching why traditional consequences fail and what works. This is helping caregivers understand brain-based differences, but this is also important for caregivers within the system of care and how we approach the adults that we work with that may have substance use disorders, that may have neurodevelopmental differences or trauma. That we think brain first, it can help reframe our approach. And then environmental support. So building structures that prevent dysregulation and crisis, that's going to be a paradigm shift within our system of care as more and more providers are able to look at brain-based differences, to destigmatize struggles with substance use, struggles with different ways of thinking. Next slide, please. Okay, so making the neurobehavioral model work, again, as I said, visual supports, multimedia supports, videos are amazingly helpful. They can be much more retained by those who are dopamine focused in their brain. Repetition, verbal instruction doesn't always stick. So those conversations that we have, those pamphlets that get tossed in the trash, well-intentioned, having a phone call check-in, having a visual that they can put on their refrigerator that's laminated, that doesn't get ripped and crumpled in their pockets, sending videos through their portals. Those kinds of things are going to be more accessible for different brains. Adjusting expectations, so helping families match expectations to their actual brain capacity and not necessarily their chronological age or what we would expect of their maturity. Reduce overwhelm, so decreasing sensory and cognitive load in environments prevents dysregulation. I'm not going to belabor that, but that's also like thinking about what are the visuals within an office, what are the sounds within your space. I think many hospitals, especially in Vermont, do a really good job of making the patient rooms very warm and friendly. But that's also like a huge part of it, right? If you're walking into a very sterile clinical setting with bright lights and the smell of hand sanitizer, you're already overwhelmed. So keeping that in mind. And preventing escalation. So without FASD understanding, families and providers escalate consequences, which can increase failure and loss of custody, residential treatment, behavioral struggles, system of care. So case management can bridge the gaps between diagnosis and daily life. Families shift from frustration to empowerment. I highly recommend referrals to early intervention family centers. I highly recommend referrals to adult case management and social work. We have the RISE programs. We have Howard Center case managers. We've got supports for adults. We also have Howard Center case management and child welfare supports and NFI as in Chittenden County. Further, there's NFI further south in the state. We also have Memorial County, Laraway. There's St. Albans supports. Throughout the state, we have case management clinical services available to youth and families. Next slide, please. So again, early identification prevents secondary complications across the lifespan. Without early diagnosis, the risk factors are increased likelihood of school failure, eventual dropout due to unmet learning and behavioral needs, higher rates of mental health disorders, depression, anxiety, PTSD. Without support, elevated risk for developing substance use disorders. I work with a lot of teenagers who are themselves using substances to self-medicate. And this speaks to that generational cycle that we see, the learning struggles, the neurodevelopmental differences that lead to eventual dropout, mental health, lack of community, and then substance use disorder. Then they have children, right? Greater chance of involvement with the justice system, increased probability of unemployment and homelessness when early identification is lacking. So with early supports and protective factors, we can have early diagnosis that enables tailored interventions that improve development and functional outcomes. Stable and understanding caregiving provides predictable environments that promote emotional regulation and resilience. Appropriate educational supports reduce learning gaps and increase engagement. Decreasing academic failure. Neurobehavioral informed interventions address underlying brain-based difficulties and improve daily functioning. And effective system coordination ensures families access services and reduce risk trajectories and support positive outcomes. So understanding the brain, thinking about the brain-based differences, the generational trauma, how we approach individuals and youth can make a large difference in early detection, screening, and supports for families with fetal alcohol spectrum disorder. As well, these early interventions and empathy will support the adults who are taking care of this next generation that's entering our system of care. Next slide, please. So recommendations, improve screening, as we've all talked about, that's going to have its barriers, but universal prenatal alcohol exposure screening in healthcare settings, as well as support. Provider education, so that's kind of my realm, trained pediatricians, educators, mental health clinicians, child welfare workers on FASD identification, symptoms, and supports for both adults and children. Non-punitive screening, accessible substance use treatment, and comprehensive postpartum support for birthing parents, and system recognition, expanding diagnostic capacity, increasing training, creating billing pathways for FASD-informed care. Now, what we can do in the current system of care is that empathetic reframing of brain-based differences, both in the adults that we're working with and the children that we're working with, coordination of services through case management, supports and referrals, as well as, I mean, just as long as, if there's an increased collaboration between psychiatry, mental health, we can work together to support these individuals and educate educators and providers on brain-based differences and feeling more supported in the system of care. Next slide, please. Again, so shifting from what's wrong to what happened to the brain, key transformation points are from blame to understanding, from punishment to support, and from symptom management to addressing root neurodevelopmental causes. So, of course, when systems understand FASD, interventions become effective rather than escalating. Investment in early identification and maternal support via lifelong prevention of secondary issues. And I put this in here because I believe that Vermont has the opportunity to lead in FASD-informed care. With compassionate understanding of brain-based differences, we can transform lives. So next slide, please. All right, so just kind of to summarize, repetition of some of what's already been said about the barriers with screening and stigma for birthing parents in substance use disorder, but also really a shift in what is available in mental health care in our state, as well as early detection of brain-based neurodevelopmental differences and how we approach those. So, thank you.
Thank you so much. That was wonderful. And I love the reframe model as we all work with, individuals throughout their journey and understanding how their prenatal environment may have shaped who they are and how that will shape our next generation. So we have a few minutes for questions. And again, we invite people to unmute and ask questions directly or to put questions in the chat, and we will read those.
Thank you so much. This was a really helpful presentation. I noticed that when you were speaking that you sometimes generalize to substance use exposure. And I have a client who's got a 6-year-old that's displaying a lot of these sorts of behaviors, and the client is on MAT. So this child was exposed to that during the pregnancy. And I'm just wondering if there's research or you have experience with children of parents on MAT having this same sort of challenge.
I don't have like direct experience with that in particular, but I will say that we know that. So through the facets lens, I focus on fetal alcohol spectrum disorder for this particular conference, but my specialty is neurodevelopmental differences in general. So we know that exposure to trauma, exposure to other teratogens, opioids, as we were talking about, there's like growing research on marijuana exposure. I don't have a ton on NAT, but symptom presentation is often an expression of brain, right? So regardless of what we're exposed to, this particular presentation is to bring awareness to. We know that we have an opioid epidemic. We know that we have growing substance use issues within our country, but specifically within the state of Vermont, that is going to impact generations of neurodevelopmental differences. But my area of expertise is autism and neurodiversity in general. So I think it's if you're seeing the symptom presentation, we want to think brain. Does that answer your question?
Yes, and I love this way to reframe it because the parent is definitely doing the, she's just willful and she won't listen sort of thing. So thank you.
And there is some evidence out there that there are similar effects with both exposure to MAT, MOUD, but that the effects are probably less prominent than if they are untreated. So I think there's also that reminder of, exposure to polysubstances or non-prescribed opioids would likely have had a more significant impact than any sort of differences we see related to MOUD. But that doesn't mean that there's no impact. There's also a strong correlation between like genetic factors as well. So it's such a milieu, right, during the prenatal environment. But I do think helping families to see like this isn't necessarily willful behavior, but this is the way that their brain is processing information, and this is how they're reacting to their environment can be a really nice way to reframe. And then I see a question from Emma. How often do you use or how effective is using teach back with adults in reference to simplifying the language in our education?
Can we clarify what teach back is? Is this just education, or is this a specific paradigm?
I think I've seen it referenced in providing information and then having the person give the information back to you. Like,
Gotcha.
yeah, yeah.
Yeah. I don't often use teachback as an approach. As an approach to simplifying language, um, in reference to simplifying the language in our education. I think it's more, from my perspective, it's more trainings with providers and educators as to how we speak to caregivers and adults. And it's also a reframe, again, of that brain-based differences. I find, and this is no judgment of mine on clinicians, but in our system of care, it can be much easier to judge adults and parents by their behaviors and their willful disobedience than it is to judge the children that we work with. Um, so it's mainly, to be honest with you, I see more benefit and productivity from empathetic conversations, validation, hearing their life experiences, being somebody that they can be comfortable talking to, has made much more of a difference than the language that I use. Of course, simplifying my language is an approach that I have. But I think using visuals and then asking follow-up questions would be my form of teach back. So like I have the luxury in my role that I work with caregivers every week. So I can follow up with them the following week and say, hey, so did you implement this? How was that? What did you think of this? Um, I also have a neurodiversity parenting curriculum that I do virtually from time to time. And in that, I have like quote homework assignments where I give them a kind of an abstract challenge. So it depends on their cognitive ability, but it'll be like, um, was there a positive experience with your child this week? Was there, how can we reframe this one episode that happened? I think curiosity is the approach. So sitting with parents and saying like, oh, I wonder where they were coming from with that behavior. Like what was behind that? We also highly utilize the phrase explanation, not excuse, um, which is, we are not saying that it's okay that your child threw something at you when you set a limit. We're saying this is where it might have come from and how we can prevent it again. Um, yeah, yeah. It's really repetitive messaging that makes the difference from my experience. And of course, simplifying the language. And I often see that the relationship that we build has the most impact. So even if you're only meeting with somebody once a month, having that very empathetic approach can help um, them feel like they can ask you questions and not feel stupid.
Well, this has been a wonderful discussion, and I really appreciate reframing this for all of us to help give us some ideas to practice in our roles. And I appreciate October also had a nice comment that she appreciates pointing out different ways of communicating with pregnant people and caregivers around substance use in a way that can be better retrained for different learning styles and abilities. And I think that is a really key takeaway from your talk.